I just want to really thank the organisers for asking me to come. It's really been a fabulous meeting, and it's only the first official day. So I feel very privileged to be here and to see a lot of friends, both adults and pediatrics. I'm going to give you quite a practical talk because I know a lot of people don't know or don't feel that comfortable managing children with chronic kidney disease. And I'm actually not going to include dialysis at all in my lecture. So starting off, I'm very privileged to work at the Red Cross Children's Hospital, which is partly funded by a charity, and so we actually do have all the bells and whistles. The difference is that we have patients who live in informal settlements less than 5 kilometers away from the hospital. So we need to make tough decisions. So just because you've got all the equipment and stuff doesn't mean that that's the right thing always to do. So the figures, unfortunately, of CKD in Africa in children is really not that easily available. I am delighted to say, however, in the last 2 or 3 years, due and thanks to papers from Gloria, Valerie, and other people in this room, those figures are slowly coming out, and I think it's really important that we actually publish those. The other issue with CKD in children is that many mothers do not have antenatal ultrasound screening. So in highly resourced countries, that would be a norm, that a mother who's pregnant would have at least one ultrasound. And so if you're asking me about screening for children with CKD, the first question I want to know is, what did the ultrasound in utero show? And I know that a lot of the moms that come to our clinic don't actually have that. And then the third issue is that AKI is very common due to diarrheal disease, malaria, sepsis, and even in our very sophisticated intensive care unit of 30 beds, we do not have a follow-up clinic that looks after kids who've got AKI, who've even been dialyzed. So we don't actually know what happens to those kids. So CKD, KDIGO, more than 3 months. Adults, you know this chart. In kids, we use the same chart. We don't really have a pediatric separate chart that I'm aware of. But what I do want to just show you is that when you are born, and you may not remember this, but when you are 1 week of age, your GFR is only 40. However, by the time you get to 8 weeks, your GFR has improved to about 66, or then up to 96. And only by the time that you are 18 months or 2 years of age is your GFR that of an adult. So we take a lot of time and effort feeding kids because we feel that we're feeding their kidneys. It's also really important at this time not to be giving them nephrotoxic drugs. I spoke yesterday in the PEDS workshop about paracetamol being the pediatrician's drug of choice. In South Africa, it's now changed to ibuprofen, which in itself is a major problem. So if you've got diarrhea and a fever, you're dehydrated, and then somebody gives you Brufen, you know you're going to be in trouble. Okay, so I teach my students 2 formulas, and I'm going to teach you the same. In adults, you have the laboratory that works out your Cockcroft-Gault or whatever in terms of a calculated GFR. In pediatrics, you have to use a calculator, but now all our students have smartphones, which all have calculators on them. So to get an estimated GFR in a child, you take the height in centimeters times by a constant. Now, we could argue for hours about what that constant is. Ours is 37.1 in our laboratory, but my 40 times table is much easier for me than my 37.1 table. So divided by your creatinine, and that gives you a GFR of a child over 2 between 80 and 120, which is what you have in adults. To our parents, I say your child's kidneys should be 100%. And so if you take a 4-year-old who's got a height of 100 centimeters, a creatinine of 100, which may not even flag on your laboratory U&E as abnormal, that GFR is only 40 or 40%. Now, no one in this room wants 40% for an exam. So that just shows you how you really need to, for each child, look at a height and a creatinine according to the Schwartz formula. So I want to introduce you to a little guy called Dylan. He's 2 years old. His weight was 10 kilograms, which is not much at 2 years of age, and his height was 75 centimeters. His BP, a good normal adult, 130/70, yeah? I've put it in italics because it's not normal. He looks fine. He's just a bit small and crooked, but he's very active and he runs around. He's He's got deformed legs, wide wrists, a very prominent forehead, which actually makes him look quite cute. So kids with CKD often look quite cute. But there was nothing much else to find, and on X-ray he had severe rickets. He actually came to us from the orthopods. Our orthopods are pretty smart. His blood results, a hemoglobin of 7, a sodium of 130, a bit low, a urea 18, creatinine 200, potassium okay at 5, calcium 2.1, phosphate 2.2, a bit high, alk phos 180, but a PTH of 30, and a venous gas which shows acidosis. So remember the formula? So his Schwartz formula works out that his GFR is 14. So if we thought 40% was bad, 14% is much worse. And we've got a little blood pressure formula, the age in years times 3, that goes up to 10 years of age, plus 100 is the 95th centile, and for him his systolic BP should be 106, and his BP was 130/70. So the American Academy of Pediatrics has just come up with some guidelines. It is a formidable document. I'm not going to share it with you, except to say that it's the follow-on from the document in 2014, which had 70,000 healthy children, and they provided norms, but many of these kids were overweight and obese. So for the recent one, they've actually looked at 50,000 normal weight children, and they've come up with normative charts. So in our renal clinic, we actually have these charts laminated for boys and girls, and you actually look at the height on the left-hand side in centile charts, and the blood pressure on the right-hand side according to your centile charts as well. So it just shows in kids you actually need to look at heights and weights according to the height, to their heights. Sorry, okay, there we go. So hypertension, the problem with kids, you need to monitor with an appropriate size cuff. Who has a pediatric cuff in their clinic? Even in our children's kidney clinic, I'm forever cursing because I can't find the right size cuff. The other issue is that ideally in kids we'd like to give ACE inhibitors provided it is not a renovascular cause for hypertension. And at the end of the day, we use calcium channel blockers. So we've moved away from nifedipine. We use a lot of amlodipine, and the nice thing about amlodipine is it's easily dissolved in water, so you can actually give a very nice dose at 0.2 milligram per kilogram once a day. Beta blockers, interestingly, cause nightmares in kids. So if you've got your kids on beta blockers, I don't know if they cause nightmare in adults, I haven't taken a beta blocker, but the idea is that if you're too tired to concentrate at school because you're on your beta blocker and your nightmares, you won't actually do well in life. So the causes of CKD, I'm not going to go into this extensively. CAC-CUT is congenital anomalies of kidney and the urinary tract, the commonest cause, which is why doing an antenatal scan is important. Genetics, we see a lot of that. Glomerulonephritis, we see a lot of post-streptococcal rapidly progressive GN. We see a lot of FSGS. And then, of course, we have those systemic renal diseases like lupus and HUS. But at the end of the day, there are often very few signs of this disease, and I actually find this really frustrating. I really hate doing renal pediatrics because there's nothing to see. If you're a cardiac, you're going to be blue around the mouth. If you're an asthmatic, you're going to be wheezing. If you're a child with seizures, everybody knows that you've got seizures. But a child with kidney failure is sometimes small and tired, and that's about it. So antenatal scan is important, and at least a quarter of our kids crash land and present to us in end-stage renal failure. So newborn baby, and you can see there's a tiny lung volume. Those lungs are very small compared to the abdomen. There hasn't been much liquor, the baby's lungs haven't developed. On antenatal scan, you can see cysts, or you can see very large kidneys, or in fact, you can even have urological problems where your bladder is very thick-walled. So that's a very thick-walled bladder that you can see antenatally. And when you do MCUGs at birth, you can see on the left-hand side the dreaded posterior urethral valve, and on the right-hand side, severe reflux. So those are the problems that we can pick up antenatally. So as I said, very non-specific, polyuria, polydipsia, a little bit pale, poor growth, and the one really important thing to ask on history is, have they had recurrent urinary tract infections? So these two little guys are actually the same age. They're both 5 years of age. And you can see the little guy on the right-hand side is extremely small, very cute, but has got end-stage renal failure. So these are the major factors. I'm just going to run through them quickly. So hemoglobin of 7, loss of energy, poor school performance. As in adults, we would give iron and folate. We use a lot of EPO. We've learned from the cyclists that EPO is obviously a good thing to do, and so we actually give a lot of EPO. Instead of giving it 3 times a week, we combine the dose and give it once a week, because most kids don't like needles. And in the same way as you guys give intravenous iron, we give intravenous iron if we need it as well. The one thing is we do not do blood transfusions if at all possible. And my junior colleagues around the hospital know that if it's Mignon's patient, you have to let the hemoglobin drop to about 4. They need to be gasping for air, and they need to be in severe cardiac failure before you transfuse them if they've got renal disease. Not for other diseases, but for renal disease. And the reason for that is I'm trying to get them to transplant. I'd rather get them EPO and IV iron and iron in case they develop antibodies, apart from all the other infections that you can get from a blood transfusion. So transfusing a kid with CKD can be a death sentence, because you can actually then get them in a situation where you can't transplant them. Anorexia, unlike adults, we don't give a low protein diet, we give a normal protein diet. You can see we give a lot of extra energy, so at least 25% normal. And this is one situation where multivitamins with all the trace elements actually work. It's cheap, it makes parents feel good, because often these kids don't have a great diet. Why don't they have a great diet? Because they have a lot of uremic nausea, they've got delayed gastric emptying, and sometimes meal times are a huge battle. The kids can't eat. We give them antacids, we give them ondansetron, and it becomes a real battlefield for children and for adults. So how do we feed them? We concentrate the feeds, we don't force feeds, and then we have to use artificial forms of feeding them. So nasogastric tube. So when I worked in the UK, a lot of kids walked around the streets of Great Ormond Street with a nasogastric tube in. I think it's difficult in Africa because it socializes you as a sick child. It's also very dangerous. You can often get aspiration into the lungs, and they come out quite easily. Kids tend not to allow plastic things around their face. They easily pull it out. You can't really reason. And so we've actually moved on to gastrostomies, either percutaneously, which we do before PD initiation, or actually open, put in by the surgeons. And you can see on the right-hand side is a little Mickey button. So that's a very small little device that you just open and you attach a feed to. On the left-hand side was the old feeding tubes that we used to use, and I've learned from my good friend Felicia Eki that no is not always no. So those are the only ones we used to get, and I've had to advocate to get the smaller little Mickey, which is much more socially acceptable. And there's a little person in her cot on an overnight feed as well as on peritoneal dialysis, and we were getting her to grow her up so that she could have a transplant. So that's the important thing about feeding. Why am I going on about feeding? Because if you've got a creatinine at birth, and I want you to look at the top over here, you can see that creatinine at birth was 450 in a newborn. But with drainage, this was an obstructive uropathy, with drainage and very careful feeding, except for a UTI, we managed to get the creatinine to stay below 300 and not dialyze this kid. So if you just look at the next slide. Slowly, we managed to get this kid from birth and give them another 7 years before they actually needed dialysis and a transplant. So feeding is extremely important in kids. If you get those calories up, and especially if the kidneys are very young, under 2 years of age, they can still grow significantly. So the other important thing is looking at your metabolic bone disease, sodium supplementation. So bone disease, a PTH of 30 is way too high. And so we reduce phosphate by using binders, as you do in adults. The only difference is that I think there's a lot of discussion in adults about calcium-free phosphate binders. A lot of our kids are so malnourished that high calciums is not an issue. So we use good old Titrolax or Rennies. We keep the calcium normal and we add 1 alpha vitamin D. If you look at these x-rays, you can see the growth plates have almost not developed at all. And you can see here cupping, fraying, and splaying, thank you, which are the signs of rickets in children. So you can see how osteopenic these bones are. The bones are skew, the wrists are wide, and so it's important to get an orthopod involved quite early. Sometimes they just clip the one side of the knee so that the legs can grow straight. So we monitor their growth very closely, and we don't use alkaline phosphatase as a marker. If you remember, this boy's ALK phos was 180, but his PTH was 30. So PTH is quite an important test. Metabolic acidosis in children, if your sodium is low, 130, you need to, and your bicarb is low, you need to add some sodium bicarb. So these kids go home adding 5 mils of sodium bicarb 3 times a day into their feeds, and that actually makes a big difference. So the one question is just growth hormone, very expensive. We don't have a single child on growth hormone in our whole clinic because we pay very strict attention to nutrition, bone disease, giving them enough fluid, and watching their anemia, and you can get away without growth hormone. Hyperkalemia, as you know, the staple diet of children in Africa would be these 3 substances, would you agree? And that's often a big problem in terms of potassium. We even have them sitting in our clinic eating that, but being on K-Exolate. Kitty mentioned that dietitians are in short supply in Africa, pediatric dietitians even more so. So hyperlipidemia, some nephrotic states have very high cholesterols. We're not sure if it makes any difference to put them on lipid-lowering agents, and there's not a lot of evidence. And so at the end of the day, your family dynamics, as Valerie said earlier, may be completely disrupted. Schooling is important, and these kids don't grow unless they get a transplant. And so we get extra points for them on the waiting list. And that's really important. The rest of the world is actually putting kids preferentially onto their waiting lists, and we followed suit in South Africa because we don't want adults to be this size with poor schooling development or schooling attendance. So just to run through those blood results, if you see there was a lot that we did. We changed the hemoglobin, we added sodium, we fixed the potassium, we fixed the creatinine by feeding, we changed the ALK phos, we worked on the PTH, and we gave sodium bicarb. And then this is just a quick paper looking at when parents come to me and say, how long have I got before this child goes into end-stage renal failure? Well, this is a paper that shows not just looking at your GFR, but looking at your diagnosis of CKD and also your proteinuria, and that children with glomerular disease show faster progression than those with congenital obstructions. I'm just going to touch briefly on palliative care. We're now calling it supportive care. So we've got an NGO called Peds Palliative Care, where they are introduced to this team before they go into complete end-stage renal failure. So Peds looks after children that are not going to have a normal length of life compared to their peers. So they do counseling, they do support, they take children on outings, and they get parents talking about the possibility of supportive care rather than dialysis. And everybody's had a case study. I have to share my case study with you. It's a mom with 3 kids, a 9-year-old with end-stage kidney disease, a 5-year-old and a 3-year-old. They live in an informal settlement. Mommy's unemployed with no support. Dad has left. They've got no running water and minimal electricity. So in our books, we would normally want them to go on to PD, but they can't. They get a child care grant. We've tried rehousing but have failed. The option is to place this child onto hemodialysis, but it means that mom would have to come to the hospital 3 times a week. She'd have to lock her 2 kids, and she was actually doing this. Lock her 2 kids in a shack on their own at the age of 5 and 3. Or alternatively, if she was not having to come to the hospital, she could obtain a job and support the family with a carer. And so you've got to ask yourself, what would you do in this situation. And we had some tough decisions to make here. So treatment for end-stage adults have rationed dialysis slots. So I think Vivek called it the death board or some board where you actually have to make decisions about life and death. In kids, we don't do that because we take a more broader picture. We look at the effects on the carers, we look at the effects on the siblings, and we think, what are we doing to that patient and the rest of their family? Because in kids, it's not a single adult, it's the whole picture. And we've actually developed a bit of a scoring system looking at family support, church support, community support, cell phones, access to the hospital, just to give us an idea. And it does cause moral distress. If you think it causes moral distress in adults, in kids, 10 times harder. But we do realize that we can't destroy families by possibly dialyzing a child in a situation like this. There are special groups of kids, so we now have 1-year-olds that are getting transplants. A lot of our kids have bladder issues. One of my adult surgeons said to me recently, we're seeing a lot of adults now that come through your service with bladder issues. You know we can't transplant them. And we're saying, well, why not? We've actually worked on sorting out the bladder, but that is a real issue because it's a new disease, if you want to call it that. We've got new hemodialysis machines. We can now dialyze a kid down to 1.5 kilograms. But just because we can, should we? And then, of course, you've got all the chronic illnesses. When a child's been on dialysis for 7 years, where do you find access? And if they are a cerebral palsy or they've got progressive brain disease, is it correct to dialyze a patient like that? If the parent really loves them, if they're prepared to support them, very difficult. And then, of course, we all have that really difficult group of adolescents. Where do they fit in? If adolescents had a kidney for a short time and lost it, is it really fair to give them another kidney compared to an adult who may be a breadwinner, who's got a whole family to look after? But we know that adolescents are difficult people. Anybody got an adolescent in their home at the moment in the audience? Anybody got an adolescent? Only 1 or 2 of you? Goodness, I don't believe that. Okay. So our cutoff is 13, and I'm going to ask you, would you give your 13-year-old your car keys and your credit card and say, go forth and become an adult? So those are difficult patients. So in closing, pediatricians, what are we good at? We're really good at keeping kids alive. What are we less good at? We're not so good at providing a quality death. And so we start making these decisions even in the ICU when they present with AKI. We don't know the prevalence of CKD in kids in Africa. You can make a big difference on a conservative basis with meticulous attention to detail and getting them to grow. And at the end of the day, care involves attention to lots of issues, but also close communication with your nephrologist. And this talk in part was for Walter, who works in Botswana, who this week has been managing as an adult nephrologist a 10-day-old baby. So for all of you who's sitting in the audience thinking this is pediatric stuff, it doesn't apply to me, I'm sorry, it does apply to you because many adults actually end up looking after kids. So I just want to say thank you very much for listening to my talk, and I hope you get some coffee after this. At the end of the day, we reach for the sky, picture of all our transplant kids at their Christmas party at the end of the year. We've made a big difference to these kids' lives, and we've tried not to destroy their families in the process. And I'm going to end off by just advertising our clinical skills course that we're going to have in February next year, aimed at pairs of doctors and nurses, and that's the contact detail. Thank you very much.